Good morning, everyone. The topic of my paper presentation is to evaluate the changes in refractive status, intraocular pressure, and central macular thickness in pseudophakic patients after Nd:YAG laser capsulotomy. Posterior capsular opacification is also known as after cataract or secondary cataract, is the most common late complication of intraocular lens implantation after cataract surgery. It is caused due to migration, proliferation, and differentiation of lens epithelial cells. It can cause significant visual symptoms, particularly when involving central visual axis. The types of PCO are vacuolated or pearl type, fibrosis type, and sommering ring type. This is a picture showing posterior capsular opacification. The treatment of PCO is Nd:YAG laser capsulotomy, that is neodymium yttrium aluminium garnet laser capsulotomy. It is the creation of an opening in the posterior capsule. The complications following the procedure involves pitting of the IOL, intraocular pressure elevation, changes in the macular thickness, retinal tear or detachment, and cystoid macular edema. Aim of my study is to evaluate pre and post changes in refractive status, intraocular pressure, and central macular thickness in pseudophakic patients after Nd:YAG capsulotomy. Objective is to evaluate pre and post visual acuity using Snellen's chart, IOP using NCT, and central macular thickness using OCT after Nd:YAG capsulotomy in pseudophakic patients. Methodology: best corrected visual acuity was converted in decimals. PCO grading was done as per Selman and Lindstrom grading criteria. In all patients, number of spots with laser energy used were recorded. Post-AIOCMT3 capsulotomy, the best corrected visual acuity, intraocular pressure, and central macular thickness were recorded on day 1, day 7, and 1 month follow-up. SPSS software was used to analyze the data considering unpaired t-test and one-way analysis of variance. My sample size was 60, including 23 males and 37 females, and duration of the study was 10 months. Inclusion criteria include all the pseudophakic patients above the age of 45 years attending ophthalmology OPD having PCO with visual symptoms and who were willing to give the written consent for this study will be included. And exclusion criteria includes patients who refused to participate in study or did not give written consent for the study, patients with posterior capsular opacification who are below 45 years of age or younger, patients with retinal abnormalities like macular pathologies, retinal detachment, or retinal tear, pseudophakic patients with corneal opacity, patients with posterior segment pathology like vitreous hemorrhage, diagnosed cases of glaucoma and on anti-glaucoma medications. YAG capsulotomy procedure. Nd:YAG capsulotomy was performed using Nd:YAG laser Apasami model 307. Patient's pupil dilatation was done with eye drop tropicamide plus 1%. Topical anesthetic paracaine 0.5% was instilled twice. Abraham YAG capsulotomy contact lens was applied with HPMC viscoelastic. Application of head strap to maintain a forehead position following the adjustment of stool, table, chin rest, and footrest for optimal patient comfort. Provision of fixation target for fellow eye was done using the fixating light of YAG machine. YAG laser energy was kept minimum 1 millijoule with gradual progression. A cruciate opening was made beginning at 12 o'clock in the periphery, progressing towards 6 o'clock and then cut across 3 and 9 o'clock and any residual tags to avoid freely floating filaments. Selman and Lindstrom PCO grading is as follows. There are 4 grades of this grading system. Grade 1 includes no or slight PCO without reduced red reflex, also no pearls at all or pearls not to the IOL edge. Grade 2 is mild PCO reducing red reflex, etching pearls confined to the IOL edge. Grade 3 is moderate fibrosis or Elschnig pearls inside IOL edge but with a clear visual axis. And grade 4 is severe fibrosis or Elschnig pearls covering the visual axis and severely reducing the red reflex. Statistical analysis. Data collected for visual acuity, intraocular pressure, and macular thickness pre and post YAG capsulotomy will be tabulated and analyzed by using SSPS software. Mean values of all the parameters will be compared.
Please summarize, no?
Yes, ma'am. These are my result. Ma'am, total mean age is 59.43 with standard deviation of 5.36. Male mean age was 59.304 with standard deviation of 5.481. And female mean age is 59.514 with standard deviation of 5.368. So this is the data comparing the BCVA pre-op day 1, day 7 and day 30. There is gradual increase in, there is visual improvement from the pre-op day to day 30. This is the IOP. IOP, there is initial rise in IOP. Following the decrease in IOP, and it remains almost same for day 1, day 7 and day 30. Central macular thickness for day 1, day 7 and day 30 is almost same. Mean value of energy used during each YAG capsulotomy is 1.81 joules. Conclusion, in pseudophakic patients after YAG capsulotomy, BCVA improves significantly without any significant increase in IOP or CMT. PCO grades and total laser energy used were significantly correlated to each other. However, they don't affect BCVA, IOP or CMT after YAG capsulotomy. Thank you.
Thank you, but you said you wanted to measure the CMT after and before the YAG capsulotomy.
Sorry, sir.
CMT, central macular thickness.
That was one of the aims of your study.
IOP,
Sir,
vision and
vision
CMT.
CMT, yes, sir.
So
What happened to CMT?
Sir, central macular thickness, there was no, sir, initially, sir, pre-op day and followed by day 1, there was increase in central macular
Okay.
thickness.
I think, okay, doesn't matter. Is there any relation of size of the capsulotomy with the complications?
Sir, size of capsulotomy.
If it is very large or very small?
Sir, actually I've compared the number of spots and the laser energy used, but
What was the cause for rise in IOP?
Sir, there is inflammation, prostaglandins and mediators, which was blocking the vitreous outflow, which caused
That means
increase in
inflammation.
IOP.
And why would you think that the vision kept on improving till day 30?
So ma'am, because the opacification we have cleared out, we have created an opening and cleared the visual axis.
No, at day 30, why did it go on improving?
Ma'am, there was improvement. Ma'am, there is settlement of inflammation also after the YAG gradually.
And also you could have excluded diabetic patients as well, because we all know that they are more prone to getting macular edema following any anterior segment procedure.
Yes.
So though in your study you didn't get any increase, but it would have been worthwhile to compare diabetics and non-diabetics.
Yes, sir.
And actually, you should have followed up these patients for more than 3 to 6 months to look for the incidence of retinal detachment. They have a very high incidence of retinal detachment, especially if you don't see the indirect outcome and the fundus with indirect outcome.
Yes, sir. Yes, sir, I'll keep that in mind.